I'm Nadine. I'm the dietitian with the Outpatient Eating Disorders program. I have worked in this hospital as an inpatient dietitian with eating disorders and another hospital as well. And then Mandy is usually the dietitian covering eating disorders at RIH. So today we're just going to talk about the reasons for admission and why patients are so different and why the goals for their admissions, their plans of care are so different, and how they can change over time. We'll also go into meal support, so what we as a team do before meals, during meals, and after meals in order to make it easier for the patient. A lot of what we talk about in this section is also applicable to other healthcare professionals and other team members, just the general approach when working with these patients. So it's not just at meal times, but how as a team having this approach and using EFFT and what Carla and Christy talked about can really make it easier. We'll do some questions, like if you guys have anything you want to ask, you definitely ask for it as well. And then depending on time, we have 3 role play examples of different situations at meals, and we'll just go through those and debrief depending how much time we have. So throughout today, we've definitely talked about different reasons for admission, and admissions are not done lightly because we don't want to overly disrupt someone's life in order to help them recover. So if they can recover as an outpatient, we'll definitely work towards that. And so the admission decision is made by their GP as well as the psychiatrist, involving their outpatient therapist, myself, and the client themselves and their family or partner if they're an adult. So it's not made lightly, and say for medical stabilization, we'll keep an eye on them in the community, and then if they get too medically unstable, that is when they would be admitted. But we know that the body is amazing and can kind of make up for all the things that we do to ourselves, and in this case, the nutrient deficiencies. They don't always show up in lab work and stuff like that, so someone can still be pretty compromised, but it doesn't show up. So sometimes, symptom interruption is that reason that they come in, because we can see the path that they're on, and if things don't change, they are going to be at a place that is pretty precarious. And some of our admissions this year have definitely been more about symptom interruption, and we've gotten lots of questions about, well, this patient is so different than the last one that we had. Like, do they need medical intervention? Why are they on the medical ward? And just understanding that, sometimes that structure that we can provide here in the hospital and on the medical ward, and having that oversight, so that when someone is refeeding, they are medically at risk, and allowing that structure and the support to change behaviors will then allow them to go back home, go to the community, and have new habits, new behaviors. As well, the refeeding process really makes a difference to brain function, and they'll be more likely to stick with those new habits, and their way of thinking will be different. So symptom interruption can be really, really helpful. Sometimes people are admitted for psychological stabilization, whether they're at risk to themselves or others, and it just depends on like a case-by-case basis whether the standard eating disorder protocol is applicable to them or not. As an outpatient team, we really try to do planned admissions because we know it's really difficult for the team on a moment's notice to get all the ducks in a row and to accept an eating disorder patient. We also know that it's really difficult for them to just, with no notice, be voluntarily or involuntarily put in the hospital. And so we just want to make it as smooth as possible. So with the new processes, we have this planned admission form that we send to the accepting PCC for the ward. It goes to, I can't even remember, staffing, shift coordinator, so they are aware to get extra staffing. It would go to the dietitian, and the accepting physician as well, so that we have everything ready. And so usually it'd be like, okay, so if we're seeing you this week, and if by next week you haven't gained any weight or your lab work is such and such, then you will need to be admitted. And there will be a bed ready and everything will be ready staffing wise. Just make it so much easier. Sometimes it doesn't work out that way. We see someone in our office and they're just at a point where they need to be admitted right then. And so still then we try to get a hold of the shift coordinator, the TCC, get staffing, get them directly to the ward. We really want to avoid having days languishing in ER because that can worsen their medical state, as well as going back and forth with the care plan that often happens if they don't have the one-to-one and the support in ER is really damaging to their recovery, as well as, yeah, their relationship with staff here at the hospital, and really difficult for you guys. As well, we definitely have people that present to emerge themselves because of their symptoms, whether it be dizziness or dehydration. So their symptoms of malnutrition, they come in, it's discovered that they have an eating disorder, and they may or may not be admitted then and there to the hospital to begin the recovery. I believe this is your slide.
Sure. It's a fluid plan. Mm-hmm. Okay. So how many people here have actually worked on either 1 South, 5 South, or 4 North with a patient with an eating disorder? Seen some of the process? That's awesome, because that's actually helpful, right? We're going to talk a little bit about logistics, the forms, process. So one of the first things we do is we need to be looking at what the goals of this admission are. And obviously that varies. We heard today a lot about the different types of eating disorders that someone can have. And so depending on who they are, what they present with, and what medical or instability or psychological concern that they've got, their care plan can be very different. The eating disorder working group has created a standard care plan, but that doesn't meet the needs of all those different types of people. So what we try to do is create the goals of their admission within the first, it's very loose numbers, sort of 48 hours. And that just depends on the day that they came in and how we can get the team together. We're trying to, in those first couple of days, really make sure that the standard care plan, it's tight, it's very restrictive, but that it keeps everyone at a certain point. And then as we've figured out who this person is and we meet, we can look at what are their goals of their admission. So maybe they don't require certain parts of the protocol. Maybe they are on the wrong unit. So we can look at all those types of things and look at why are we keeping something here. The other benefits are we can start to say to someone as we work through, and we don't necessarily give the patient those end final goals, because otherwise we start to end up with some negotiating as we start to hit a few things. They want to know what the rate is, if that's what their goal is, those types of things. But within us as a team, we can start to direct what's our care plan going to look like, what services we need to put in place, what support do we need to give them, and how long is this process going to get to. I've always looked at these types of patients as having about 3 kind of phases. The first stage is that real crisis, medical stability, lab work, bed rest, starting for some of them to just get them eating some food. Get them on a plan, get them moving forward, get them buying in a little bit to our process. And that first stage can be really, really tricky. The second stage is generally the longest stage, and that's our let's kind of, whether it's gain some weight, slowly get them to a place where they recognize and they want recovery, they start to buy into the plan, they feel better about themselves eating. So we're kind of just making some gains. And stage 3 is a little bit more about, we've kind of hit a place where we can start to do a bit more psychotherapy. We try to get the team in as much as we can, or we can just start to work with them on what does discharge home going to look like. Are they willing to accept some supports, those types of things. Sometimes that might even be a transfer to 1 South if they started on 4 North. So there's lots of different plans. But if we have a point where we can say we need to make sure that these few things are done, it's really very helpful before we kind of kick them out the door, but provide the team some structure as well. So things like, obviously, electrolyte medical stabilization. We want to make sure someone's medically stable before they leave. Someone may come in with dramatic weight loss, they may not. They may actually be in an okay place. And we're working a little bit more on meal plan stabilization or introduction of fear foods and their normalization of how they eat, their eating behaviors, the types of foods that they eat. And sometimes a little bit more emphasis is put on that symptom interruption. So if binging, purging, weighing of foods, the exercise regimen that they're on, all those different types of things, we've removed that from their life. And by simply having them here for a few weeks and then starting to see that they can cope without those other coping strategies, and start to eat a normal meal plan or something that closely resembles it, we can then send them home in a bit of a safer place so that then they can take on that outpatient treatment and work on that long-term stabilization. New computer page now. Okay, so looking at plan of care. So we've talked about, depending on what their goals of admission are, we need to create a framework, something that's going to really support all of the team and the patient for understanding what's their admission going to look like. So again, where they are, what their diagnosis is, what issues they have, what their stressors are, or the sky's the limit. There's so many things and we'll get into it, that we want to make sure works for the patient. So when we create the plan of care, again, we start with a very strict version when they come in because we don't know who they are. But the goal at that first team meeting is to create something that's key and works for them. And then we build off of it. So we talked a little bit about when you've got that juicy tidbit of information. This worked really well. You know, sitting with someone, holding their hand when they were crying. We got to the point where talking really wasn't necessary, but just being present, spending that time was really valuable today, getting that charted in there. So what are the things that help the person? And it's okay to ask them. I'm sorry I'm new today. What's worked in the past? What's worked to get you through breakfast? You know, I just got here, it's here, we gotta do this. What can I do to be supportive for you so we can get through this? That's, as we've talked today about control and how control can start this, and control is heavily ingrained throughout the whole process, we're giving them control. You can say, this is something that we're going to do together. But what can I do to help you, or what works for you, right? But then passing that information back and forth, and then following the framework as well. Because if in the first team meeting we've addressed and said this isn't an issue for someone, they can actually have movement privileges, so they can go to the bathroom. You need to understand that so that you don't get pulled into a conversation where they say, well, yesterday they removed that, and now you're feeling like, are they splitting me? Are they actually allowed it? I want to support them, but they're just being manipulative. No, they're genuine. They could be, but knowing that care plan in and out so that you can safely enter that conversation with them. Well, based on the care plan that I have right now, this is what I have, but I'm happy to go back and we can talk about this as a team or bring that up at the next team meeting. This is good information. We want to support you. And if that's not a concern, we can definitely address that. So you don't have to address it in the moment, but by creating them a voice and a plan, because we do weekly team meetings, they again get to bring their concerns to the table. So offering that, but knowing where you are when you walk in is really helpful to continue it. So definitely the consistency between everyone by knowing your information before you walk in, which when you come on shift at 7:30 and you have to start things like breakfast at 7:45 is tricky. So the team is working on that, trying to look at the documents and how we can pass the information. Looking at the actual plan of care, one-to-one support is crucial. So who has time to sit with someone for 4 hours as they're sobbing? It's day one that they've been here. You don't. If you're the primary nurse, that's really tricky in anyone's day. I understand what it's like to have a number of patients you have to get through. And yet you genuinely want to spend time and help this person through this terrible, traumatic first day. So having a one-to-one support is crucial. So utilizing your team, working together, and if you are the one-to-one support, it's not just meal time. You're there to stare at them while they get that food in and then watch the 90 minutes. They haven't purged, they haven't left the bed. Is that what they need in the moment? No, they really, as all of this emotion work has gone through, we're realizing that this is a 24-hour jail cell where we're forcing them to do some things. That's how they probably feel. So having someone sitting there and helping them and identifying, and sometimes they might just need space. Sometimes they might need someone to do the puzzle with them and not speak because they're overwhelmed and they maybe just want to hide a little bit from what's happening. But being there, being present, having as many people in the room at certain times, being that consistent message, just being present to help them through, especially as I talk about that first phase 1 where they're really, really struggling and this is a scary, horrible place for them. That's crucial. So I'm very excited. We advocated hard from the eating disorder working group, and we've got awesome administrative support. If we've got staffing, they will give it to us. So advocate, use them, but that doesn't mean if it's you've got a one-to-one staff, the primary nurse doesn't have to do some of that work too, because remember we talk about connection, building those relationships, and if it's a care rate doing one-to-one support, they may not have this training that you do. They may not have known the person from another time. So utilizing your team, having more than one person as well coming in to bring the message of consistency of the care plan and working together to help the patient. Monitoring is crucial. Obviously we want to try and provide that support, but obviously keeping an eye on what they're doing. Food is medicine. So there's not many times in a dietitian's career you can say that food is actually a really big deal. Usually someone trumps you with a brain surgeon. You know, I don't know. I went to school. I think I'm everything. When they're at a stage of being admitted, food is a really big deal, and it might be the actual consumption of calories. Sometimes it's the introduction of a food they haven't eaten in 10 years. Sometimes it's the fact of just putting something in their mouth. So food is a really big deal. And I bring this up because we've had questions where, well, today was a really tough day. You know, this isn't really, you know, the emotions were high. It just didn't go well. Breakfast didn't happen, sorry. Which, yeah, we need to look at, well, what are we going to do? We have to tweak our care plan now because the meal supports, you know, they weren't prepared to eat 1,200 calories today. We have to address that, and that's the team's job, and that's my job. But recognizing that food with this type of patient is the same as getting them home. Food is crucial. Food is getting their brain functioning again, getting the right nutrients to their brain, starting to get their body recognizing food. So if they have that tummy ache, they're bloated today, which is not going to happen. What can we do differently? Because we have to get some food, because food is the medicine. Until we can get them to the place where they can start to do more of that psychotherapy and actually work towards recovery. Activity. Why is activity such a big deal? We've talked a little bit today about things like burning calories, you know, not letting them have that. Has anyone ever witnessed someone sitting in their bed and they're wondering what's happening? Like the sheets are up to here? Right?
Or legs shaking.
Yeah. Or sitting in a chair with their feet up. How many calories can you burn using one of the biggest muscles in your whole body all day? Lots. They know those things. So supervision, monitoring what they're doing for activity is a really big deal. Things like bathroom privileges. Do people have questions about things like why do we have restrictions on bathroom privileges?
I think my question would be, when is the door open? When is the door closed?
That's mine.
When is the door locked? You know,
When are they singing in the bathroom?
when are they singing in the bathroom? When are they not? I know for everybody it's different, but it's kind of like, I feel we should be monitoring their bathroom more.
So it's a great question. I get it all the time. Mm-hmm. There really shouldn't be a question, but I think some of it comes down to our own personal comfort with this piece of the care plan. You don't want to sit on the toilet and have a poop while someone's watching you. Who does?
I can't.
You probably could.
I can't. I'll hold it for days.
Yeah, I get it. So we know that we're trying to support them by having some supervision and monitoring so that if they're going to purge, we are aware. And are they bad for doing that? If the emotions were overwhelming and they did purge, are they bad? No, it's an opportunity for us to understand, know what's happening for them, so we can get there and say, all those things you guys learned earlier, right? I can see this is really tough for you. That was hard for you to keep breakfast down. Okay? That's the point of watching them.
Would it be easier, like, to have like a specific bathroom on 4 North for eating disorder patients where the water's turned off? So they can't flush the toilet, so we can see, did they purge, did they?
If we were an inpatient treatment center that only had patients with eating disorders, you could have things like that. But it's very tricky when we haven't had a patient since beginning of August on 4 North.
What? I just admitted somebody last week.
Yeah, I was gonna say, it was like 12 hours, guys. But so you have those breaks, and there's so few bathrooms in a place like 4 North, you can't justifiably do that. But what we're doing is understanding the rationale why we do some of these things. So when someone's in the bathroom having a bowel movement, it's not that you're staring at them, it's not that we can see them. The idea behind singing and talking and things like that is about them not being able to use their esophagus to vomit, essentially. And so if they're just sitting having elimination, you could, and I can be well behind the door. I'm not, that's your privacy. I can be trying to, give, as long as I can kind of hear that, we're good. We do try to get past that, and so that might be some of your confusion as well. We try to get through bathroom supervision as fast as possible. And use of psychiatry, medical consulting physicians, anyone who can really get to the nitty gritty of what someone's history is. If we can, the more we feel confident, because someone can come in on day 1 and we don't know them and they say, no, I don't do that. I don't know who you're talking about, so I get full permission to the bathroom. They may never have been a purger before, but they maybe aren't used to eating so many calories, and now we cause that, right? Because that's a new coping strategy when they're so fearful to eat that food. So there's different things that we want to try to pick up and see how the progress go, which is why we have regular meetings, so we can identify and say, this is something that we no longer have concerns about. Things have been going well. How do you think things are going? So I think it's important to have that information that comes from the care staff as to how the day has gone, that every day has gone, what you're seeing concerns, what the anxiety and stress level are after a meal. Is this a new concern for someone, or are they were at a point of recovery and they were crying out and we kind of had some good, they're doing okay. They're increasing their meal plan and they're scared as heck, but they're hanging on pretty good, and we don't need to invade their privacy, so to speak, anymore. So it's something that we look at. The golden rule is, until that's lifted, we're trying to make sure we know what they're doing in that room. And if they're flushing the toilet beforehand, chart that. And then say to them, what happened? As they're heading in, remind them of the expectations. So please don't flush before I have a chance to look. And then if they do, okay, what was going on? Oh my gosh, I totally forgot. But every other time they're perfect. Well, it's all of our second nature to turn and flush, so that's gonna happen. If they always flush quickly, having that charted and then having that communicated to the team is an invitation for an opportunity for the rest of the team to say, what's happening? It's not, you're bad, you must have puked. Who cares? Instead, we want to get to their level. We want to have that courageous conversation about what we can do to support them, again, towards their own goals of not needing to purge after they eat food. So that's a conversation that you can have if you're feeling comfortable with it, and you can pass to the team to make sure that other people can have that conversation. Again, good communication, passing that back, talking to the PCC, the dietitian, the physician, so that the consistency is also there, because we also know that you might be on here today and then you won't have the patient again for ever. Okay. Visitors, some of the concerns of visitors is actually about not every person, even in our immediate family, is supportive towards recovery. And sometimes they might be that trigger, or sometimes they might be the person that
brings some laxatives.
Lets them use the cell phone?
Yes. There is a lot of that, and again, it's one of those things that we can't restrict everybody and wait until everyone proves themselves, but we try to create a safe space where we minimize some of that risk. So as we talked about feeling of sadness, frustration, anger, but also when you add that layer of previous stressors or trauma, we have to also make sure that we're creating that safe place, the reassurance that we're here, we're protecting them. Okay, so that's another one of those things that just understand, put yourself in their shoes, hear them out, we can bring it to the next team meeting and we can talk about that.